hiker attempted to prevent altitude sickness with a common diuretic. This is what happened to his motor function. HJ, a 42-year-old male, presents with acute onset flaccid paralysis. He cannot lift his hands and his potassium levels have plummeted to a life-threatening 1.8 milliequivalents per liter. The clinical problem originated when he consumed 4 liters of mineral water containing over 500 milligrams per liter of bicarbonate, alongside his acetazolamide. This created a renal trap that flushed his electrolytes away. HJ was training for a high-altitude trek when he woke at 4 in the morning feeling an impossible heaviness in his limbs. When he tried to check his phone, his fingers refused to curl. Within minutes, he was a prisoner in his own body, fully conscious but unable to move his legs or arms. In the emergency department, the medical team observed ascending flaccid paralysis, a terrifying loss of muscle tone climbing from the feet upward. While HJ could still speak and move his eyes, his lower extremity reflexes were completely absent. This is areflexia, from the Greek a meaning without, and reflexio meaning to bend back. His body was no longer responding to its own internal electrical commands. Doctors had to determine if this was a permanent neurological collapse or a chemical glitch in his blood. At 6:30 a.m., the medical team shifts their focus from the brain to the heart. An EKG monitor reveals a disturbing electrical landscape. The T waves, which normally represent the heart resetting, have flattened into the baseline. In their place, strange prominent bumps called U waves appear, a classic sign of profound electrolyte instability. While searching for a trigger, a resident uncovers a digital ER note from 3 weeks prior. It reveals that HJ was prescribed acetazolamide, also known as Diamox, as an altitude prep for his upcoming climb. Suddenly, the lab calls with a critical value. His serum potassium is 2.2 millimoles per liter. Normal levels are 3.5 to 5.0. At 2.2, his nerves and muscles lack the electrical gradient required to fire. This is hypokalemia, from hypo meaning low, kalium for potassium, and emia meaning in the blood. When questioned, the patient's wife adds a final, crucial detail. To alkalize his body, he has been consuming 2 liters of bicarbonate-rich mineral water every single day. This specific combination of a drug that alters kidney chemistry and a massive intake of alkaline water created a metabolic trap. This combination triggered a massive alkaline load that forced his kidneys to dump potassium into his urine at an accelerated rate. To understand the cellular failure, we must look at the distal convoluted tubule where the drug and the water created a profound osmotic diuresis. You see, the acetazolamide he took is a carbonic anhydrase inhibitor. Carbonic refers to carbon dioxide. Anhydrase means an enzyme that removes water. By inhibiting this enzyme in the proximal convoluted tubule, the medication blocks the reabsorption of bicarbonate. This turns his kidneys into a leaky boat. Normally, the pump keeps essential electrolytes on board, but the drug broke the pump, allowing bicarbonate to spill out into the urine. This is a potent diuretic, from the Greek dia, meaning through, and urein, to urinate, which forces the body to flush fluids. As the bicarbonate fled, it dragged sodium and water with it. This massive surge of fluid reaching the distal nephron tricked the body into thinking it was dehydrated, triggering the renin-angiotensin-aldosterone system, or RAAS. This hormonal border guard desperately tried to save sodium, but it did so by trading away potassium, throwing it into the urine at an industrial scale. When HJ drank 2 liters of bicarbonate-rich water, containing over 2,000 milligrams per liter of base, he provided the ultimate fuel for this fire. His body attempted to dump the bicarbonate surge, and in that frantic process, his kidneys opened the gates, allowing his remaining potassium to flee his bloodstream entirely. This chemical exodus left his muscle cells without the electrical charge needed to move, effectively unplugging his entire motor system. The drop to 1.8 milliequivalents per liter meant the resting membrane potential of his muscle cells became too negative to fire an action potential. Without this electrical excitability, the skeletal muscles of his arms and legs became completely unresponsive to signals from the brain. The serum potassium deficit reached a critical threshold where it could now cause fatal cardiac arrhythmias or respiratory failure. As serum potassium levels bottom out, the heart muscle becomes dangerously irritable. Without enough potassium to stabilize the electrical charge across cell membranes, the heart's internal timing goes haywire. This risks a descent into ventricular tachycardia or the chaotic fatal twitching of ventricular fibrillation. This is an arrhythmia, from A, meaning without, and rhythmos, meaning rhythm. Simultaneously, the paralysis climbs to the diaphragm, the primary muscle of respiration. HJ begins to feel as though he is suffocating while wide awake, his chest too heavy to expand. Deep in his limbs, the starved muscle cells begin to rupture, a process called rhabdomyolysis. Rhabdo means rod-shaped, myo refers to muscle, and lysis means breakdown. This disintegration releases toxic myoglobin into the blood, which clogs the renal tubules. The result is a secondary acute kidney injury, or AKI, as his kidneys fail under the weight of his own dying tissue. The transtubular potassium gradient, or TTKG, remains high. This confirms that the kidneys are still aggressively pumping out the very mineral he needs to survive. To stop this spiral, the medical team initiates aggressive potassium replacement therapy. HJ feels a sharp, searing burn in his veins as the team begins the infusion. Because concentrated potassium is highly caustic to small vessels, it must be dripped in slowly. It is like a controlled electrical recharge for a dying battery. Within 12 hours, the electricity finally returns to his nervous system. The heavy, leaden weight in his limbs begins to lift, first a twitch in his toes, then a weak but victorious grip on the doctor's hand. By 24 hours, the resolution of his paralysis is nearly as rapid as its onset. The medical team explains that his healthy mineral water was the specific trigger that turned a common medication into a metabolic weapon. This case serves as a vital reminder that the kidneys are a delicate balancing act. Even natural supplements can disrupt the fine-tuned electrical gradients that keep our hearts beating and our muscles moving. HJ was discharged with a strict warning: never combine carbonic anhydrase inhibitors with bicarbonate loading. Thank you for watching this breakdown on anatomy of a mistake. This case demonstrates how high bicarbonate intake can turn a standard dose of acetazolamide into a catalyst for severe hypokalemic periodic paralysis. For more detailed breakdowns of electrolyte imbalances and clinical pharmacology, subscribe to Anatomy of a Mistake and join the discussion below. Take care of yourself and be well. This is a composite teaching case for curiosity and education, not a transcript from a real chart, and not personal medical advice. See a licensed clinician about your own symptoms or care.